I think the most pressing needs in treating patients with polycythemia vera and essential thrombocythemia remain, at least especially in polycythemia vera, is the maintenance of strict hematocrit control. That is, hematocrits less than 45%. It's been well shown when hematocrits exceed 45% that those patients have an increased risk of thrombosis. It is less well established whether control of platelet numbers or white blood cell count is needed to optimally manage patients with polycythemia vera. We've therefore embarked on a study of a drug called PTG 300 or rusfertide, which is a hepcidin mimetic that essentially chronically controls hematocrit levels below 45% in patients with polycythemia vera. This is a drug that's administered on a weekly basis subcutaneously and has been associated with minimal side effects beyond that at the local injection site, therefore leading to long-term hematocrit control, therefore not requiring subsequent phlebotomies and not having the patients for periods in between visits having hematocrits above 45%. I think the goal in future therapy with essential thrombocythemia is even more problematic. It is assumed that normalization of platelet numbers leads to a decreased thrombotic risk in patients with essential thrombocythemia. That assumption is not well founded, since numerous authors have shown that irrespective of the platelet count that is achieved with the variety of therapeutic interventions used, does not preclude the patients developing additional thrombotic episodes. So we need a lot more information about the etiology and biology of thrombosis in patients with essential thrombocythemia in order to interrupt these thrombotic processes. Treatment of patients with polycythemia vera and essential thrombocythemia is a difficult process because it requires long-term studies in multiple institutions for prolonged periods of time, which have been difficult to sponsor either by pharmaceutical companies or by academic institutions. And only with the execution of these studies, which will last probably over a decade with large numbers of patients, will we ever learn if a particular therapeutic intervention essentially reduces the incidence on thrombosis and truly prevents progression to myelofibrosis and MPN blast phase. That's really the major challenges.